If you take a blood pressure pill every morning, the same one, the same glass of water, the same routine, how confident are you that it is protecting you during the hours your cardiovascular system is under the most strain? Not the hours you spend walking to the kitchen, not the hours you spend sitting in a chair, the hours between 4 in the morning and 9 in the morning when blood pressure spikes sharply in most adults over 60, when the heart works harder than at any other point in the day, and when the majority of heart attacks and strokes in this country actually occur. Most people take their blood pressure medication when they remember, when they wake up, when breakfast is ready, when the pill organizer is in front of them. And for many of those people, the medication they swallowed at 7 a.m. has already been doing its most powerful work between midnight and 3 a.m., while they were asleep, while their blood pressure was naturally at its lowest. And by the time the real biological storm arrives at 6 a.m., the protection has quietly begun to fade. This is not a theory. The relationship between blood pressure medication timing and cardiovascular outcomes is one of the most actively studied areas in hypertension research over the past 15 years. And what the research keeps revealing is not a simple answer. It is something more useful than a simple answer. It is a framework, a set of specific questions about your specific medication, your specific blood pressure pattern, and your specific daily behaviors that, now when answered, tell you and your doctor exactly when your pill should be taken to do the most good. A quick and important note before we continue. This channel is dedicated to reviewing what the published research actually shows and explaining it clearly. Nothing in this video is medical advice. Do not change the time you take your blood pressure medication based on anything you hear here without first speaking directly with your prescribing doctor or pharmacist. Blood pressure medication timing is a clinical decision, and changing it without guidance can be genuinely dangerous. With that clear, here is what the science actually shows, and why this conversation with your doctor is one worth having soon. Stay with the full explanation today, because there is a finding specific to a subset of adults over 60, where the current timing of a blood pressure medication is not only less protective than it could be, but may be actively creating a window of risk during the most dangerous hours of the cardiovascular day. That finding is in the second scenario we cover. Do not skip it. Right now, drop your age and what time of day you currently take your blood pressure medication in the comments below. I read every one of these, and the pattern of when this audience is dosing shapes what this channel covers next. Here is what your blood pressure is doing while you are not paying attention to it. Blood pressure is not a fixed number. It is a biological rhythm. Rising, falling, rising again across every 24 hours, in a pattern so consistent it has its own clinical name, the circadian blood pressure rhythm. In a healthy cardiovascular system, blood pressure follows a predictable arc. It is lowest in the deep hours of overnight sleep, typically between 1 and 3 in the morning. Then, beginning around 4 a.m., as the body prepares to wake, a cascade of hormonal signals fires, cortisol rises, adrenaline increases, the sympathetic nervous system begins activating, and blood pressure climbs sharply, rapidly, and in most adults over 60 to levels that are measurably higher than anything recorded during the day. By 7 or 8 in the morning, blood pressure in untreated hypertension frequently reaches its daily peak. Think of it as a daily tide. All night the tide is out. Blood pressure low, the cardiovascular system in relative quiet. Then, before the alarm sounds, the tide comes rushing back in. Fast, forceful, and in a heart and vascular system that has been at rest for hours. That surge lands on vessels and cardiac tissue that have not been gradually warmed up to it. This is why more heart attacks occur between 6 and noon than at any other 6-hour window of the day. It is why strokes cluster in the early morning hours. It is why the blood pressure reading your doctor takes at 10 a.m. after you have been up for 3 hours, after the morning surge has already partially resolved, may be a less alarming number than what your arteries experienced at 5:47 a.m. while you were still in bed. Now layer in a blood pressure medication taken at 7 a.m. after breakfast, when that morning surge is already well underway or already beginning to peak. The medication begins working, but its peak effect arrives 2 to 4 hours later, around mid-morning, when blood pressure has often already started its natural midday decline. The drug is most powerful when the body needs it least, and its protection thins out precisely as the body's next vulnerable window begins. This is not a pharmacology abstraction. This is the specific pattern behind why timing matters, and why the conversation with your doctor about when you take your medication is not trivial. Consider someone like Harold. He is 72, a retired postal worker from rural Kentucky, diligent with his medications and thorough about his health. He took his amlodipine every morning at 7:15, always with breakfast, exactly as his doctor had instructed. His office blood pressure readings were consistently fine, 128/78, sometimes better. He felt well. He assumed his medication was working perfectly. What Harold did not know was that his home monitoring, which his daughter had encouraged him to start after buying him a blood pressure cuff for his birthday, was telling a different story. His readings at 6 a.m., before the medication, were routinely running between 158 and 172 systolic. His overnight numbers, recorded by an ambulatory monitor his doctor eventually ordered, showed his pressure never dropped at night the way it should. And the morning readings in that 5 to 7 a.m. window, readings that no office visit had ever captured, were the highest numbers in his entire 24-hour cycle. Harold is a composite, a pattern that appears consistently in the hypertension monitoring literature, not a specific individual. But his story represents one of the most clinically significant and most commonly missed problems in blood pressure management after 60. He was treated. His medication was real, but the timing of his protection did not match the timing of his risk. Here is why that pattern is more common than most people realize, and here is the first of the specific scenarios that determines whether your current dosing schedule is working with your biology or against it. The morning surge is not the same in every person over 60. In most adults, it is significant but manageable, with appropriate long-acting medications taken consistently. But in a subset, estimated at roughly 30 to 40% of older adults with hypertension, the morning surge is exaggerated. The blood pressure does not just rise, it spikes. It climbs 30, 40, sometimes 50 points systolic within a 1 to 2 hour window before full waking. This exaggerated morning surge has been independently associated in multiple studies with higher rates of cardiovascular events, not because the average blood pressure is poorly controlled, but because the peak is violent enough to stress vessels that might otherwise hold. For these individuals, a medication taken at 7 a.m. is pharmacologically behind the curve from the moment it enters the bloodstream. The surge has already begun, and the only way to know whether your morning surge falls in the exaggerated category is ambulatory blood pressure monitoring, a device worn for 24 hours that records pressure at regular intervals, including the 4 to 8 a.m. window that clinic visits never capture. Research published in the Journal of Hypertension has documented that exaggerated morning surges, independent of average 24-hour blood pressure, carry meaningfully higher cardiovascular risk. The vessel wall stress from a sharp, rapid pressure spike, even brief, initiates inflammatory signaling in the endothelium that compounds over years of daily repetition. The right medication at the right time can blunt that spike before it begins. The same medication timed for maximum effect at noon cannot. Ask your doctor about ambulatory blood pressure monitoring. If you have never had one and you have been on blood pressure medication for more than a year, the information it returns may change the conversation about your treatment timing significantly. Now, scenario 2, and this is the one I told you to stay for. There is a finding in the human blood pressure research that applies to a specific group of adults over 60, and if you are in that group without knowing it, your current medication schedule may be leaving you most vulnerable during the most dangerous hours of the cardiovascular night. In a healthy blood pressure pattern, pressure drops by 10 to 20% during overnight sleep. This overnight dip is not incidental. It is biologically necessary. During those dipping hours, the heart rests. The blood vessel walls experience reduced mechanical stress. The kidneys process the day's fluid load at lower pressure. The cardiovascular system uses the quiet of sleep to repair and recover. Adults whose blood pressure does not dip, or whose pressure actually rises during sleep, are called non-dippers. And the clinical consequences of being a non-dipper are substantial. Research published in Hypertension, the Journal of the American Heart Association, found that non-dippers had significantly higher rates of left ventricular hypertrophy, kidney damage, and cardiovascular events compared to dippers with similar average daytime pressures. The overnight window without the protective dip becomes a period of continuous vascular stress rather than recovery. The heart never fully rests. The vessels never fully decompress. Non-dipping is more common after 60 than at any earlier point in life. It is associated with chronic kidney disease, sleep apnea, autonomic nervous system changes that accompany aging, and the cumulative vascular stiffening that makes older arteries less responsive to the natural signals that normally drive overnight pressure reduction. Some analyses suggest that as many as 40% of older adults with treated hypertension are non-dippers, a finding their standard office blood pressure readings would never reveal. Think of the difference between a dipper and a non-dipper, like the difference between a factory that shuts down for a proper overnight maintenance cycle and one that runs all 3 shifts without stopping. The one that never stops does not get repaired. It accumulates wear. It degrades faster than its specifications predict. Not because anything went acutely wrong, but because the restorative downtime was never built in. For non-dippers, the clinical literature has examined whether shifting some or all blood pressure medication to evening or bedtime timing can help restore the overnight dip and reduce cardiovascular risk. The evidence here is genuinely mixed and requires honest framing. A large Spanish study of the high-GIA chronotherapy trial, published in 2019 in the European Heart Journal, reported dramatic reductions in cardiovascular events with bedtime dosing compared to morning dosing. Those findings generated significant clinical interest. But a subsequent, larger and more rigorously designed trial, the TIME study, published in The Lancet in 2022, followed over 21,000 patients and found no significant difference in cardiovascular outcomes between morning and evening dosing across the general hypertensive population. What this means, honestly, is this. For the average person with well-controlled hypertension on a long-acting medication, the evidence does not currently support that bedtime dosing is broadly superior to morning dosing for preventing cardiovascular events. But for specific individuals, non-dippers identified through ambulatory monitoring, those with documented exaggerated morning surges, and those on specific short-acting drug classes, timing decisions made in partnership with a physician based on their individual 24-hour pressure profile carry real clinical importance. The word for every person watching this is the same. You cannot know which category you are in without measurement. And the measurement that matters, 24-hour ambulatory blood pressure monitoring, is not routinely ordered in most hypertension follow-up visits. Ask for it. The information it returns is the difference between managing a number and managing a rhythm. Let me stop here for just a moment. Even when we talk about blood sugar, kidneys, sleep, or everyday senior health habits, one thing is always connected: the heart. That is why the team at Senior Insight Press created Heart Safe After 60, a simple guide to help seniors spot the warning signs before it is too late. It is a complete 55-page guide that covers every cardiac warning sign, the 10-minute emergency protocol, the overnight protection system, and a 90-day heart protection plan you can start implementing today. Most importantly, it includes the full list of cardiac tests your doctor may never have ordered for you, including the lipoprotein A measurement and the coronary artery calcium score that can predict a cardiac event with remarkable precision. The link is in the description. It is from Senior Insight Press, published specifically for adults over 60 who refuse to leave their heart health to chance. Now, let us get back to our topic. Scenario 3. And this one is the most practically useful because it gives you the specific questions to bring to your next appointment based on the drug on your pill bottle. Not all blood pressure medications behave the same way across a 24-hour period. The timing that is optimal for one class of medication is different from what is optimal for another, and most people, including many who have been on their medication for years, do not know which class of drug they are taking or what that means for timing. Here is the breakdown that matters. Diuretics, the water pills, hydrochlorothiazide, chlorthalidone, furosemide. These medications lower blood pressure partly by reducing fluid volume. They do this by increasing urination. The practical implication for timing is direct. A diuretic taken in the evening or at bedtime will produce its peak urinary effect during overnight hours, disrupting sleep with bathroom trips. For the vast majority of patients, diuretics belong in the morning, early morning before the day's fluid intake begins, not because of cardiovascular timing optimization, but because the alternative costs sleep, and disrupted sleep in older adults raises blood pressure, increases cortisol, and undermines the very system the medication is trying to protect. Think of it as routing the drainage system during the day shift when the pipes can work without waking the whole household. Calcium channel blockers, amlodipine, nifedipine, diltiazem. Amlodipine specifically is one of the most prescribed blood pressure medications in adults over 60. It has a half-life of 35 to 50 hours, meaning it stays pharmacologically active in the bloodstream for nearly 2 full days after a single dose. For a medication with this duration, the difference between taking it at 7 a.m. versus 9 p.m. is clinically modest for most patients. What matters far more than the clock time is consistency, taking it at the same time every day without missing doses, and ensuring that if any timing adjustment is made, it is done with your prescribing physician's knowledge and not independently. CE inhibitors and ARBs, lisinopril, ramipril, losartan, valsartan. This is the class where the timing discussion becomes most nuanced and most individual. These medications work on the renin-angiotensin-aldosterone system, the hormonal cascade that regulates blood vessel constriction and fluid balance. This system has its own circadian rhythm, with activity peaking in the overnight and early morning hours in many patients. For individuals who are non-dippers or who have documented early morning surges, some clinical evidence supports discussing evening dosing of this class with a physician. The time trial's neutral finding applies across the general population, but your individual profile may differ significantly from the average. The question to ask your physician, based on my 24-hour blood pressure pattern, is the timing of my specific medication class providing peak coverage during my highest risk hours? Scenario 4. Consistency. And this is the one that the timing conversation most often obscures because people become so focused on morning versus evening that they lose sight of what the research identifies as the single most important timing behavior of all. A blood pressure medication taken at the same time every day, regardless of whether that time is 7 a.m. or 10 p.m., maintains steadier plasma concentrations than a medication taken at irregular intervals. Plasma concentration steadiness is what prevents gaps in protection. A gap in protection is a window during which blood pressure, unmedicated, returns toward its untreated baseline. In an older adult whose untreated baseline is 160 or 170 systolic, that gap is not trivial. Research on medication adherence in hypertension has consistently identified irregular dosing timing, not just missed doses, but variable timing from day to day, as a significant contributor to poor blood pressure control, despite technically being on an adequate medication regimen. Think of it as keeping a fire burning. The specific log you add does not matter as much as whether you add it before the last one has turned to ash. Miss the window consistently and the fire goes out, briefly, daily, in ways that accumulate over months into measurable vascular damage that would not have occurred with consistent timing. If you currently take your blood pressure medication at irregular times, sometimes with breakfast, sometimes before bed, sometimes whenever you remember, this is the single most important change to make before any conversation about morning versus evening optimization begins. Set an alarm. Choose a time that fits your daily routine without exception. Anchor it to something you do without fail. Brushing teeth, a specific meal, a morning or evening routine that does not vary. The consistency of that anchor matters more than where it sits on the clock face. Scenario 5. The morning behaviors that interact with timing in ways most people never consider. Coffee, grapefruit juice, sodium-heavy breakfasts, intense physical exertion immediately after rising. Each of these has a documented interaction with blood pressure medication timing that is worth understanding, not as a reason to avoid them, but as a reason to sequence them thoughtfully. Caffeine causes an acute, transient rise in blood pressure, typically 8 to 10 points systolic, lasting 1 to 3 hours. In a person whose morning blood pressure medication is just beginning to absorb when the coffee is consumed, the medication and the caffeine are working in opposite directions at the same time, with the caffeine's effect arriving faster. This does not mean eliminating coffee. The cardiovascular literature on moderate coffee consumption in older adults is actually favorable over the long term. It means being aware that consuming coffee immediately before or after a morning dose of a fast-acting blood pressure medication creates a brief period of competing physiological effects. Grapefruit juice is a more serious concern for specific medication classes. Grapefruit and grapefruit juice contain compounds called furanocoumarines that inhibit an enzyme called CYP3A4 in the gut wall. This enzyme is responsible for metabolizing certain calcium channel blockers, particularly felidipine and nifedipine, and to a lesser degree amlodipine, before they enter the bloodstream. When grapefruit inhibits this enzyme, more of the medication reaches the bloodstream than the prescribed dose intends. Blood pressure can drop further than anticipated. The timing interaction is specific. Grapefruit effects on CYP3A4 can persist for 24 to 72 hours after consumption. This is not a one-meal risk. If you take a calcium channel blocker and drink grapefruit juice regularly, raise this with your prescribing physician or pharmacist at your earliest opportunity. Scenario 6. The afternoon and evening risk that the morning dosing conversation almost never includes. Blood pressure in most treated older adults reaches its lowest point of the day in the early to mid-afternoon, a natural circadian dip compounded by the peak effect of a morning medication dose. For most people, this is not a problem, but in older adults who are also taking other medications that lower blood pressure as a side effect, certain alpha blockers, some antidepressants, medications for benign prostatic hyperplasia like tamsulosin, the combination of circadian low and peak medication effect can produce blood pressure that drops low enough to cause dizziness, lightheadedness, or near fainting on standing. This phenomenon, called orthostatic hypotension, is one of the leading contributors to falls in adults over 65. A fall in this age group is not a trivial event. Hip fractures carry a 1-year mortality rate in older adults that exceeds the mortality of many cancers. And orthostatic hypotension driven by poorly timed or overstacked blood pressure medications is, in many cases, preventable with a careful timing review. Think of the body's blood pressure regulation on a multiple medication afternoon as a car with 2 drivers, both turning the wheel the same direction at the same time. One driver is the circadian dip. One driver is peak medication effect. The car goes further than either driver intended. And in a body where the mechanism that normally compensates for position changes, the baroreflex, has already slowed with age, Going too far can mean a fall before the system has time to correct. If you stand up after sitting or lying and regularly feel a swimming sensation, a rush of lightheadedness, or a brief moment of visual dimming, do not dismiss this as age. Describe it to your doctor with specifics: when it happens, how long it lasts, what time of day, and what medications you have taken in the preceding hours. This is a solvable problem with the right clinical conversation. Now, the lines that must be stated without ambiguity. Do not change the time you take your blood pressure medication on your own. Do not skip a dose to experiment with a different timing. Do not switch from morning to evening based on anything you have heard or read, including this video, without speaking with your prescribing physician first. Blood pressure medication timing changes can temporarily destabilize control in ways that carry real cardiovascular risk during the transition period. If you experience chest pain, sudden severe headache, vision changes, facial drooping, arm weakness, or slurred speech, call emergency services immediately. These are not symptoms to evaluate after a good night's sleep. They are emergencies. If you experience severe dizziness, near fainting, or actual fainting after taking your blood pressure medication, contact your physician the same day. Do not drive until you have been evaluated. Here is the picture drawn together. Your blood pressure medication is not wrong because it is prescribed for morning, and it is not automatically right because you have always taken it that way. What the research says, clearly, consistently, across multiple lines of evidence, is that the relationship between when you take your blood pressure medication and how well it protects you is determined by three things your physician cannot know without specific measurements: your 24-hour blood pressure rhythm, whether you are a dipper or a non-dipper, and whether your morning surge is within typical range or exaggerated. Those measurements require a 24-hour ambulatory blood pressure monitor. They require a clinical conversation that goes beyond the standard office reading, and they require asking a question most patients never ask, and most physicians never raise, not because it does not matter, but because the appointment is short and the refill is easy. The question is, given my specific medication, my specific blood pressure pattern, and my specific daily routine, is the time I am currently taking my pill the time that provides maximum protection during my highest risk hours? That question, brought to your next appointment, opens a conversation that may not change anything, or it may change something that matters considerably to the next decade of your cardiovascular health. You stayed through this entire video. That matters. It means you are the kind of person who takes their health seriously, who understands that the information you have before midnight is worth infinitely more than the information you wish you had after. Senior Insight Press created Heart Safe After 60 for exactly you. Inside, all 7 warning signs explain the way they actually feel in an older body, not the Hollywood version. The complete overnight cardiac risk protocol, the 10-minute emergency action plan, designed to be printed, laminated, and posted on your refrigerator tonight. A 12-point cardiac emergency preparedness checklist, and a 90-day heart protection plan that turns what you have learned into daily, trackable action. The link is in the description and pinned in the comments below. It is $67. Instant download. That is less than one emergency room copay, and it could prevent you ever needing that copay at 3 in the morning. Download it tonight, print the emergency protocol, put it on your refrigerator before you go to sleep. Your heart has been working for 6 decades. It has earned the protection of someone who knows its warning signs. Now tell me, what time do you currently take your blood pressure medication? And has any doctor ever ordered a 24-hour ambulatory monitor for you? Drop it in the comments below with your age. Your answer may be the most useful piece of information someone else in this community finds today. And here is where this leads next. Because the timing of your medication is one variable, but there is a second variable that most people on blood pressure medication after 60 have never been told about, and it concerns what you eat and drink in the 2 hours surrounding your dose. Specific foods consumed in that window can reduce your medication's effectiveness by up to 40%, not by interacting with the drug chemically, but by activating competing physiological pathways that the medication was not designed to overcome. That video is the natural continuation of everything we covered here, and it will be linked when it goes up. Take good care of yourself. You have earned that.